Good evening, ladies and gentlemen. Welcome to monthly clinical update in neonatology, which is organized by Ceylon Association of Neonatologists with collaboration of Perinatal Society of Sri Lanka. Today, the topic is approach to ambiguous genitalia. The disorders of sexual differentiation is a spectrum of disorders that all of us have encountered in our clinical practice at some point. It has medical as well as endocrinological problems, or it could manifest as a medical emergency. It also has psychological concerns related to determination of sexual identity. Therefore, let's update our knowledge about this condition. Tonight, the speaker is well known for her career, and I hope she needs no introduction. She is the first pediatric endocrinologist in Sri Lanka. She is a coherent speaker in national as well as international forums in pediatric as well as endocrinology. And she is a well-known academic researcher. Most importantly, an excellent teacher and a clinician. She is Dr. Navoda Atapattu. Madam, over to you to deliver your lecture on approach to ambiguous genitalia.
Good afternoon, good evening actually. Thank you, Jitma, and thank you, Association of Neonatologists, for inviting me to talk to you on approach to ambiguous genitalia, which is actually a daunting task to cover within 30 minutes or 45 minutes, but I will try my best to make it clear and be practical in relation to our society, our culture, and for the available investigations that we have in hand. So when a baby is born, before anything, a mother and the father or the relatives would ask whether this is a boy or a girl. That's the first question, even before they inquire about the health of the baby and the mother. So sometimes this is not very clear. This problem is faced mainly by the gynecologist as well as the neonatologist. However, gynecologist can say, okay, you speak to your baby doctor. And now the baby doctor, that is you, the neonatologist or the pediatrician who is looking after this neonate, would face the challenge of giving an appropriate sex of rearing. So this is something that you would see, either undervirilized boy or an undervirilized girl. It's 1 in 4,500 to 1 in 5,000 live births. You would see a child with ambiguous genitalia. So what is it? What is ambiguous? Which means where the newborn is born with the most appropriate sex of rearing is not immediately clear. So you are unable to say whether this is a boy or a girl. The most appropriate sex of rearing is not clear. So what is a disorder of sex differentiation? That is a congenital condition where the chromosomal, gonadal, and anatomical sex is atypical. And subset of patients with disorders of sex differentiation present at birth with ambiguous genitalia. So why it is an emergency? First, we have to find out what is the sex of rearing. And this ambiguity also depends on the expertise of the examiner. You may perceive the patient is ambiguous, but someone else may not. So it depends on the expertise of examiner. Sometimes it is very important that you examine these patients properly to identify whether there is any ambiguity. Sometimes it is not very clear and you may even miss a slightly virilized female who would present to you in 2 to 3 weeks' time with a soul closing crisis. So it's very important that you examine these patients properly. Even after expert examination, sometimes this may not be very clear even for the experts. And there are concerns about early medical problems, as I explained you earlier. Most of these patients with ambiguous genitalia, especially when it is come to 46XX DSD, 90% of them can have congenital adrenal hyperplasia. Even though 46XY DSD is the commonest type, they also can have impaired adrenal function. Not only 46XX, even 46 DSD patients can have impaired adrenal function. Say even a patient who is coming to you with only micropenis, which is where you know there is no ambiguity of sex determination, but the patient is having a micropenis. Micropenis is also categorized under disorder of sex differentiation. That patient may be a person with hypopituitarism where adrenocortical axis is affected. So even a 46XY not ambiguous patient will have a condition called impaired adrenal function. So even a patient with micropenis need to be investigated. And there could be underlying etiological diagnosis. 46XY DSD, only 50% can have clinical diagnosis, and out of them 30% will have a genetic diagnosis. So it becomes a diagnostic dilemma for the physician who is caring these children. And there can be future health issues like future risk of tumors, fertility issues, sexual function, and also it may be very difficult to explain and resolve the dilemma around these patients with DSD, mainly because of the social and cultural influences. So why it is a psychological emergency? Family attitude and function, family cultural factors, perception of the child's condition, ability to interpret complex medical and genetic information, they all become psychological emergencies for parents as well as the physician who is looking after this child. And also, it depends on the parents' capacity to manage uncertainty related to gender assignment. Sometimes even we are finding it difficult to say exactly whether this person is going to be sexually functional, what the fertility would be, what the behavior would be, what the gender identity and the gender role would be in future. We may not be able to say exactly, even we can't give a percentage what type of problems they would be able to anticipate by looking at the patient. Even sometimes after all the investigations, we may not be able to tell exactly what to expect. And also, it becomes an emergency based on the approach of the healthcare workers. Sometimes, not the medical staff, but other staff make certain comments which give rise to these psychological issues in the parents of these families. So what do we do immediately after a baby is born with an ambiguity? This is most important for the neonatologist who is looking after this child, who is the first contact person. And you will have to explain according to the level of understanding. And you have to explain that we have to delay the gender assignment. And you should explain that there's nobody to be blamed for giving birth to a child with this condition. It is not the father's problem. It is not the mother's problem. It is not something that mother has taken during pregnancy. Things like food, maybe drugs can affect it. It's a different story, but sometimes people tend to blame the mother, especially for giving birth to a child like this. And also make sure you use gender neutral terms to refer the baby. Rather than boy or girl or ambiguous baby, say that this is a baby. And engage the parents while examining the baby so that they will also understand there is a problem and you are trying to solve it. And they feel that you are helping them. And use gender neutral terms to describe the anatomy. Rather than calling a penis, call it a phallus. Rather than calling it a vaginal opening, call it a single perineal opening or two openings. Labioscrotal folds, gonads. Don't say it is a testis or ovary, say it is a gonad. And examine the baby with the parents always. And also be sensitive about repeated examination by multiple trainees. Of course, we have to train our trainees, but make sure that you do not examine these patients repeatedly and um, make comments of these about these patients in front of everybody. Sometimes patients and actually sometimes parents come and tell me that this patient was subjected to examination by several medical students and they were making a lot of comments which made them disheartened. So be sensitive when you examine this type of patients. Don't try to take photographs unless it is really needed for the expert opinion. I know some of our colleagues take photographs and send those to us, but it is only for medical opinion, not to be published anywhere. So you have to explain the mother that you are taking this picture just to get a medical opinion from another colleague who is working in a faraway place, because you have to solve this problem as early as possible, and that is why you are taking this picture, not for anything else. And also make sure that the parents should be encouraged to bond with their newborn. Breastfeeding is very important. I don't have to explain how important the breastfeeding is, but make sure that the bonding is taken place during the first few days. Otherwise, these parents may reject this baby in time to come. And also, please order investigation in consultation with other specialties. Sometimes we have to delay certain investigations and we have to consider the timing of these investigations, and these investigations should be done after specific simulation studies. So it is better if we can discuss before doing these expensive investigations. Sometimes we have to send this to outside laboratories. And when the results are available, we have to discuss the results with the parents, and all of us should get together and come to a consensus and then disclose and explain the results to the patients, rather than then and there informing these results, so that it will create uncertainties when we have to say something else later on. And we have to encourage them to delay a formal announcement of the birth unless they can disclose it to close family members that there is a small issue and doctors are investigating to find out whether the baby is going to be a male or a female. But definitely there is going to be a sex. There is no intermediate form. Either the baby is going to be a male or female, depending on the investigation. Sometimes, rarely, it is not immediately clear. We will have to wait for a while until we do all the tests and see whether this is a boy or a girl, not an intermediate type of a person. So how do we classify these conditions? From here onwards, it is going to be theory. Previously, I explained practical things. Now, these three types, sex chromosome DSDs, those are the patients with Turner syndrome, Klinefelter, patients with mixed gonadal dysgenesis, or even ovotesticular DSD, come under sex chromosome DSD. Then this group of patients with 46XY DSD, it is a problem of either gonadal development, or it is a problem of androgen biosynthesis or androgen action, or LH hormone receptor defect, or anti-Mullerian hormone defect, where the Mullerian structures are remaining inside the body, but the baby is a boy. Usually their penis is normal, and they will get identified when they go for surgeries for undescended testes or inguinal hernia. Then the surgeon would see both testes on one side, or maybe a fallopian tube will come out from the inguinal area. They are boys. The problem is the anti-Mullerian receptor was not formed. Because of that, Mullerian structures were remaining. So 46XX DSD, it could be either a disorder of gonadal development like ovotesticular DSD or a gonadal dysgenesis, or disorder of androgen excess, either fetal or fetoplacental or maternal origin. And there are other anatomical syndromic causes of DSD. As an example, cloacal anomaly unfortunately comes under DSD. It is not an endocrine problem. It is an anatomical problem. However, it is classified under DSD. So how do we evaluate? First of all, we have to get a thorough history to find out what we are dealing with. The consanguinity is a very important information that we have to get. Previous history of ambiguous babies, history of amenorrhea in female siblings, unexplained sudden infant deaths, maternal history of hirsutism and virilization that will tell us whether there was a problem of the fetal-paternal unit, aromatase, placental aromatase deficiency, which can cause female fetus virilization, or whether it is a maternal exposure to hormones, including exogenous hormones or used in assisted reproductive methods. So that is where we have to find out what drugs the patient has got exposed to, but it should not be a blame game. The consanguinity, we have to be very sensitive because we are directly pointing fingers at those people and they will feel guilty of their decision of marrying a related person. Of course, we need to know, but we have to make sure that we address it very sensitively, and we should not be asking that same question over and over again during our history taking. Are you related? Are you related? Which means you are blaming because you are related, your baby fell sick. So we have to very careful. We need this information, but we have to be very careful when we ask those questions also. So when you evaluate the baby, just look at the mother to see whether the mother is virilized or mother is cushingoid. That will tell us whether mother was suffering from androgen secreting tumor. Look for dysmorphic features. Some 46XY DSD patients can have associated dysmorphic features. Certain syndromes, babies with certain syndromes are born with ambiguous genitalia. So look for those. Look for the pigmentation of the baby. Look for midline defects. Any ambiguous baby should be investigated or evaluated for other midline defects, especially the cardiovascular. 30 to 40% of 46XY DSD patients can have cardiac abnormalities, including critical aortic stenosis. So even sometimes, even before we diagnose the reason for 46XY DSD, you might have to send this patient to the cardiologist to survive the child. Afterwards, we can investigate and find out why this patient developed this ambiguous genitalia. And also it's important to note the size of the phallus, width of the phallus, where the urethral orifice is, whether the labioscrotal folds are fused, whether it is rugose, determine the presence of gonads. If the gonads are palpable, you know that you may be dealing with the 46XY DSD or ovotesticular DSD. If the ovaries are not palpable, and even if it is not seen on ultrasound scan, but the baby is sterilized, very likely that you are dealing with a patient with congenital adrenal hyperplasia. But if the and Prada scale and EMS, that is external masculinization score, which I explain little later. And if you miss these initial examination findings, they will present to you around 2 to 3 weeks of age with evidence of salt loss, dehydration, jaundice, hypotension, and tachycardia. Now, the next question most of the neonatologists would face is which book to give, blue or pink? When you want to transfer the patient for further evaluation, you have to give BCG vaccination, you have to mark it in a CHDR and send. So you have to find out whether you are going to give a blue book or a pink book. That is the most important question that you are going to face immediately before the transfer. So practically, with the available facilities of this country, in other countries, they can get the presence of Y chromosome within 24 hours. We are unable to do that. So if you get a patient with a palpable testes, palpable gonads within the scrotum, and the phallus is of reasonable size, close to 2.5 centimeters, this child will be brought up as a boy. So give a blue book and send the patient to the hospital. If the patient does not have gonads ultrasonically or palpable. If it is not palpable or ultrasonically it's not there, most likely it is a CAH. If the patient is pigmented and if the gonads are not palpable, Mullerian structures are there, you know this is a virilized female. So this virilized female will be brought up as a female. So best guess is for you to give a pink book. But tell them not to register the baby, but give a book. Then there is some assurance that this baby is going to have a sex later on in life, rather than a green color book, which we don't have. So examination of external genitalia is extremely important when it comes to ambiguity, just to look at, see whether the where the urethral orifice is, whether the labioscrotal folds are fused, where the urethra is, what the penile length. These gonads are seen here, palpable, and what the size of phallus. Yes, the gonads are there, phallus is very small, and this very severe labial adhesion. So the degree of virilization is categorized under 5 stages. When there is no virilization, there's a normal female. Stage 1 is a patient with mild clitoromegaly without labial fusion. These are the patients you would miss if you are not careful to examine. Stage 2, there is clitoromegaly, but a slight fusion of the posterior part of the labia here. But there are 2 separate openings. Stage 3, the greater degree of clitoromegaly, and the perineal open is single, and there's a common channel. Stage 4, increased phallus size, urethra-like urogenital sinus at the base of the clitoris, and there is complete labial fusion. And stage 5 is penile clitoris. The urethra is at the tip. It's a completely virilized female. Will present to you like this. This is the most problematic form of CAH that you would come across, because the surgical procedures are very difficult to make them female, and there are a lot of surgeries involved, which can result in damage to neurovascular bundle and loss of sensation at the genital tubercle. And because of the surgery, they can get urinary incontinence, pelvic floor issues, dyspareunia. They may not like to mother a child, and they will have a lot of sexual dysfunctions, because antenatally they have got exposed to a lot of androgen. So their sexual behavior would be different. So these patients from the very beginning need psychological support. And if the parents are not ready to bring them up as females, you will have to wait till the child is able to give the consent for the surgery. Then during the pubertal time, you will have to give GnRH analog to prevent them getting menstruation and menstrual bleeding through the urethral meatus. If the parents do not feel that they should bring up these patients as females, if they want to continue as males, we will have to wait till the child is ready to give the consent. Then we will have to block the puberty by giving GnRH analog, especially when it comes to this type of patients. I would rather happy to receive this type of patients, not this type, because it's a very big discussion together with the surgeon as well as the psychologist and the parents. Most of the time, they don't understand what is happening. And the other one is this external masculinization score for the 46XY, where the patients with palpable gonads. The total score is 12 here. Even score 11 or less than 11 needs investigation, which means if you get a patient with undescended testes, unilateral undescended testes require investigation. If you get a patient with distal mid-urethral meatus, mid-shaft urethral meatus, he or she needs investigation. So even though this masculinization score comes as 12, even if it is 11, these patients needs investigations. In other words, everybody needs investigations. What the most important is the karyotyping. But remember, the mosaicism is also there. It could be tissue dependent. So if you happen to see a prenatal karyotype and if the postnatal karyotype is different, you will have to think of tissue mosaicism and also look for the cis-RY gene. Imaging would be the most important out of all these because karyotype takes at least 1 month in our country to receive. But most experienced sonographer will let us know whether the Mullerian structures are there, whether the gonads are there, or whether both structures are there. That type of information we can get from an experienced sonographer. Biochemistry, if they are acutely ill, we need to check electrolyte and blood sugar. But on the even if you suspect a patient as having congenital adrenal hyperplasia, you don't have to do electrolyte after 48 hours. It is not going to be deranged. These electrolytes and blood sugar starts deranging maybe 1 to 2 weeks later. But it's important that you send 17-OHP, DHEAs. These investigations can be done depending on the type of virilization, depending on whether the gonads are palpable, whether the gonads are not palpable. However, the 17-OHP, please send only 48 hours after birth if the patient is not acutely ill. If you send 17-OHP on acutely ill patients early, or if you do it on any preterm babies, we don't have reference values, so it's very difficult to interpret. We might have to do it again, which means another cost. That is why we request to discuss these investigations with us before sending it to outside laboratories. And for certain patients, we need to check gonadotrophins. As we go on, you will understand why we need those: testosterone and androstenedione, DHEAs. These are all adrenal androgens. AMH and inhibin B will tell us the function of Sertoli cells. If these AMH is high and inhibin B is high, we know that the Sertoli cells are functioning, which means testes are there somewhere. HCG stimulation test will help us in finding out testosterone to dihydrotestosterone ratio or androstenedione to testosterone ratio in certain conditions associated with 46XY-DST, which I will explain later. So let's move on to 46XX disorders associated with androgen XX. So virilized female. So this is the common, most important androgen biosynthetic pathway, where if there is, the commonest is 21 hydroxylase deficiency, the 17-OHP starts rising, and the precursor molecules get shifted towards this pathway, dihydroepiandrostenedione and androstenedione, which get converted to testosterone and virilize a female fetus. Male fetus doesn't have any problem other than the pigmentation, and they may come little late if you do not pay attention to the pigmentation or the family history. If it is a 3-beta hydroxysteroid dehydrogenase deficiency, girl will be virilized, boy will be under-virilized. And here, yes, 17-OHP is also going to be high, but more than that, DHEAS is going to be high. Both these conditions are associated with aldosterone deficiency, cortisol deficiency, testosterone excess. Those are the two common types of CH. And you may be having these uncommon types of adrenal insufficiency where steroid acute regulatory enzyme does not allow the cholesterol to enter into the mitochondria so that the pregnenolone is not formed. This is the precursor molecule for all these pathways. So those patients can present to you with collapse. Females will not have any ambiguity, but the boys may be ambiguous or may have normal male genitalia, or maybe look like a female with the testes. So it is very important that we identify this entity because this could be a life-threatening condition. So there is a very big genotype-phenotype correlation. So those salt wasters present early and they don't have any enzyme activity, 0% enzyme activity. They present like salt wasting type of CAH. When they have some amount of enzyme activity, They will present during the neonatal period, but they are not salt wasters, but simple virilizing form. When they have significant amount of enzyme activity remaining, they will present at a later age with non-classic CH, where virilization takes place after 2 to 3 years of age. So this is an important area to discuss, especially when it comes to a country like Sri Lanka. Asian culture and Western culture look at these issues in different ways. So yes, we can prevent virilization by giving dexamethasone antenatally, but it has to be started 7 weeks before 7 weeks of gestation. And it can be discontinued if the chorionic pillar sampling or amniocentesis indicates that the fetus is male, or if the genetic analysis indicates that the fetus is unaffected. During this exercise, you are treating 8 fetuses to save 1 fetus. So there is a group of babies who get exposed to dexamethasone unnecessarily. And these antenatal dexamethasone, early exposure to dexamethasone can result in verbal, non-verbal intelligence issues, verbal working memory problems, visuospatial working memory problems in those who get affected to antenatal dexamethasone. So the Endocrine Society Clinical Practice Guideline, this is not updated yet, 2018 is the latest. They say prenatal therapy for congenital adrenal hyperplasia should be avoided due to an incompletely defined postnatal risks. But if you are to do that, you have to do it under ethical approval, ethically approved protocols. And those babies who get exposed to antenatal dexamethasone should have appropriate follow-up, and those data should be shared with other societies and other countries, so that will help future management protocols. So if you are doing this, if you have to start antenatal DEXA, you have to ideally take ethical approval. Asian countries, so this stigma is so much. Countries like UAE, they prefer, even though the guidelines say not to use dexamethasone, those countries prefer to use antenatal dexamethasone to prevent female fetal virilization. Western world think it is not ethical, so because they don't have that much of cultural, social issues, they can wait till the child is ready to give consent for sex reversal, or they can take their own decisions. Because of that, they are not too worried about this virilization. Because of that, they say you have to get ethical approval before you start dexamethasone. This is always a controversy, but you can discuss, and given the benefit of the social circumstances, you may start this, but remember to follow up the patients who got unnecessarily exposed to dexamethasone in terms of those behavior issues. So CAH is a medical management. As you know, we have to give hydrocortisone and fluorocortisone to prevent salt losing and dehydration and collapse. We have to make sure that they get timely surgical interventions, close monitoring, psychological support. And remember, they can have fertility issues, and this has to be done in a multidisciplinary team. As they get older, they have all other medical problems, hypertension, polycystic ovary disease, subfertility, problems of gender identity, sexual behavior, sexuality. All these problems are anticipated, so we will have to monitor them very closely. This is the Prada stage I explained earlier. So this is Prada 3. Other virilizing conditions, placental aromatase deficiency, androgen secreting tumors, and androgenic drugs. You will find this out from the history, and these things will regress. Or if the clitoral size is too big, they can undergo clitoral reduction. And there is this very rare entity called 46XX testicular DST, where the testis is present. SRY gene is not there in patients who are presenting with ambiguity. SRY gene is there in persons who are presenting later on in life with fertility issues. So the differential diagnosis in this condition is O testicular DST. Yes, they do have testes, but the gene is 46XX. So these patients are generally brought up as boys. This is the summary of 46XX DST. Yes, ambiguous genitalia, do the karyotype, and do our ultrasound scan. No uterus, it has to be a 46XX testicular DST. If the uterus is present, do 17 OHP of the baby. If the baby is normal, 17 HP is normal, you may be dealing with a patient with O testicular DST. If the 17 OHP is increased, you know you are dealing with CH. If the 17 OHP is normal, look at mother and see whether the mother is virilized. And in that case, it could be maternal virilizing disorder, either drugs, deuterium of pregnancy, or aromatase deficiency. Most important two investigations at the beginning are ultrasound and the karyotype. 46XY DST, gonads are palpable in the scrotal folds or in the inguinal region. Scrotum is bifid, urethra is perineal. So three types, either defective differentiation, either deficiency of testosterone production, or defect in testosterone metabolism or action. Very easy. Either gonad is not formed properly, or the testosterone is not produced, or the testosterone is not acting. Dysgenetic gonads there are two types. Complete gonadal dysgenesis, they look like females. They can have palpable gonads or intra-abdominal gonads with Mullerian structures. Because the gonad are dysgenetic, AMH is not produced, so that they can have remnants of Mullerian structures. They should be brought up as females, and the gonad should be removed because it increases the risk of gonadoblastoma. The other group is partial gonadal dysgenesis. They can manifest with a range of genital ambiguity. One side the testes, the other side the testes would be intra-abdominal or in the inguinal region. If you do an ultrasound scan, you would see Mullerian remnants on one side. Usually the karyotype is 46XY or 45X to 46XY. And the sex of rearing always depends on the degree of virilization and the surgical expertise. A lot of discussion should happen before deciding on the sex of rearing. We need the surgical expertise to find out which way to go. In those patients, the testosterone levels are low and have high LH and FSH because the gonads are not functioning. The pituitary gonadal axis is stimulated so that LH FSH levels are in the in very high range, like in a menopause female, very high levels of LH and FSH. Testosterone and AMH levels are also low because AMH is low because the sertoli cell function is less. This is what I explained earlier. If you decide to bring up a patient with gonadal dysgenesis as a female, remove the gonads as early as possible. If not, if you try to bring up this patient as a boy, then you will have to do the surveillance of gonads and with the low threshold for gonadectomy. And we advise them to do self-examination when they are big. And we have to do regular ultrasound scan and tumor markers to identify early tumors and remove gonads. And there's another entity of 46XY DST. If you do the investigations, yes, karyotype is normal, testosterone is normal initially, and other gonadotrophins are normal, 17 OHP normal, cortisol normal, everything else is normal, but the patient is having ambiguous genitalia with 46XY. This group could be due to one of these genetic mutations associated with WT1, and these patients have high risk of having Wilms tumor and early nephrotic syndrome and renal failure. So these patients, in other countries, if it is a 46XY DST undifferentiated, they do check the WT1 and keep these patients under surveillance for developing Wilms tumor and nephrotic syndrome. What we do is we do ultrasound scans regularly, maybe 6 months to annually, and also UFR, which is very non-invasive. then and there we do the UFR just to make sure that we are not missing an early diagnosis of WT1. We have diagnosed 4 patients. We have screened and diagnosed 4 patients. 1 patient died of severe acute renal failure. Other 2 are living without any issue, but have resistant nephrotic syndrome, but haven't got any Wilms tumor as yet. So it is very important that we at least screen them and diagnosed early, even though the treatment options are limited. Deficiency of testosterone production. It could be a Leydig cell hypoplasia where testosterone levels are very low and the gonadotrophins are high. You do the HCG stimulation test, testosterone is not produced, which means there is Leydig cell hypoplasia, patient is unable to produce testosterone. The sex of rearing has to be female. And other enzymatic defects, this is this complex adrenal steroid pathway. So these are the problems that they can have. At various different places, things can go wrong. ACTH is high in all these conditions. 17-OHP is low in first 2 conditions, star and P450, where the cholesterol entry, and 3-beta, 17-OHP high, 17-20 lyase is low, and P450, 17-OHP is high. All these conditions, cortisol levels are low, renin levels are high. So the treatment is steroids, mineralocorticoid, and testosterone later on in life. Where the adrenal and testicular steroidogenesis is affected. Here, only the testicular steroidogenesis is affected, 17-20 lyase and 3-17-beta. So they need only testosterone and the surgery. So it's important that we do all these investigations to differentiate what we are dealing with. Other one is defects in testosterone metabolism or action. First one is 5-alpha reductase deficiency, where testosterone does not get converted to dihydrotestosterone. Dihydrotestosterone is important in the virilization of the external genitalia. So they can have variably masculinized external genitalia. They don't have Mullerian structures. There is a very big overlap with partial androgen insensitivity and testosterone biosynthetic defect. Because of that, it's important that we do this test, because 5-alpha reductase deficiency patient should be brought up as boys, because there is a tendency for them to virilize at puberty. Even if their genitalia look Prader stage 1 to 2, you should exclude 5-alpha reductase deficiency if you are to bring up this patient as a female. If it is a 5-alpha reductase deficiency, you have to bring up that patient as a male. If it is not, you may consider bringing up that patient as a female. If so, which means if you are going to bring up a patient with 46XY DSD as a female, you have to exclude this. And the other one is androgen insensitivity. It could be either complete or partial. Complete androgen insensitivity, again, you can bring them up as females. They can have very small phallic-like structure. Testes are palpable. No Mullerian structures. Gonadectomy can be done after breast development, and they can lead a full sexual life but subfertile. Partial androgen insensitivity, they can present predominantly with micropenis or hypospadias and bifid scrotum. Normal or high testosterone levels. Again, sex of rearing depends on the surgical expertise. And they can develop gynecomastia at puberty. The treatment is either high-dose testosterone or dihydrotestosterone. If the family and the surgeon decides to bring them up as females, we need surgical feminization, gonadectomy, replacement with estrogens at the time of puberty, and vaginal dilatation. This is the summary of 46XY. Gonads, palpable. Is the uterus there? No uterus. Check the testosterone, high. Dihydrotestosterone ratio high, 5-alpha. It is not high. Testosterone to dihydrotestosterone is not high. Androgen insensitivity syndrome. Testosterone low, do 17-OHP. If it is high, P450 oxidoreductase deficiency. If the uterus is present, testosterone is low, partial gonadal dysgenesis. If the testosterone is low, 17-OHP is checked and it is normal, it could be hypogonadotrophic hypogonadism, Leydig cell hypoplasia, 17 beta hydroxylase dehydrogenase deficiency, where androstenedione does not get converted to testosterone, or it could be 3 beta HSD2. Testosterone low, 17 OHP is also low. It could be lipoid adrenal hypoplasia, congenital adrenal hypoplasia, higher up in the steroid biosynthetic pathway, the defect has taken place. If the uterus is present and the testosterone is normal, do the gonadal biopsy. It could be a ovotestis. So it is ovotesticular TST. If the testis is normal, it is persistent Mullerian duct syndrome. Gonads not palpable. Uterus, yes. Check testosterone. If the testosterone is normal, it is ovotesticular. Testosterone is low. Uterus is present. Gonadal, partial gonadal dysgenesis. Gonads not there. Uterus, no. Testicular regression. Those patients will not have ambiguity. They will have micropenis. Sometimes micropenis, sometimes normal penis, no testes. 46XY, they need testosterone at pubertal age. O testicular DST is the most rare form. Commonly seen karyotype is 46XX. Simultaneously, they have ovarian and testicular tissue. They don't have 4 gonads, they have 2 gonads. And in each of those, both testicular and ovarian tissues can be seen. Gender assignment represents a great therapeutic challenge because it's a lot to explain and it depends on what the parents and the patient needs. Sometimes sex reversals will have to take place depending on what the child would want. These are 2 examples, same condition. So 12-year-old girl presented to us with pubic hair and virilization. Examination revealed inguinal testes were in the inguinal canal, very big. Phallus was 4 centimeters, scrotum bifid with a perineal urethra. Testosterone levels in the adult male range, no Mullerian structures. Parent, both child and the mother wanted to continue as a female. So until the child was 16 years of age, we gave GnRH analog to prevent further virilization of the child because the testosterone is being produced. Now the child is in puberty, so we had to block that. We gave GnRH analog to block testosterone and estrogen to get breast development. And when the child was 16 years of age, gonadectomy was done. This year, we did the gonadectomy on this child. Then the 18-year-old girl presented with the need to change over to male sex after being brought up as a girl. He had always wanted to be a boy for several years, but the parents denied. She was a karate champion in the girls category. And he had normal male hormone profile. Testes were palpable in the scrotal folds. Phallus was 7 centimeters with a perineal urethra. And later on, parents understood that they have to support this sex change. And then he changed the school, changed the registration, underwent surgery. She changed over to a male because this could probably explain 5-alpha reductase deficiency, virilizing at pubertal age. So the management is we need a team of people, endocrinologist, gynecologist, surgeon, urologist, radiologist, geneticist, pediatrician, and psychologist. Everyone is needed here for appropriate management of these various different problems that we encounter during their lifetime. So gender assignment is influenced by genetic diagnosis, appearance, fertility potential, surgical options, and views and circumstances of the family relating to cultural biases. So all these things are influenced when it comes to gender assignment. Gender assignment, nearly all excess infants with functional ovaries are brought up as females. XY brought up as boys, except when the external genitalia are more female than male, like in CAIS. And testes are absent with LH receptor defect and hypoplasia. Follow-up is surgical, medical, psychological, and gynecological. So if you look at this picture as in summary, here testes are there. This is the phallus. So this child would benefit from bringing up as a female. It's very difficult to give this child a functional testis. So we have to exclude 5-alpha reductase deficiency and then bring up this child as a female. This is a phallus with the gonads in the inguinal region. You have to bring up this patient as a male. This was a 5-alpha reductase deficiency. This is again a PGD patient. Decided to bring up as a boy because of the size of the phallus. The parents felt it was reasonable to bring up this child as a boy. So thank you very much for your attention. Any questions I may, if possible, I will answer.
Navoda, I'm Aman here.
Yes.
Hi, thank you very much for your comprehensive and very simple explanation of a very complex subject. And first of all, I'm really grateful and thankful to you for taking your time and doing this lecture for the benefit of the neonatal
Neonatal community, I would say.
community, yes, neonatal community. We have nurses, doctors, so all range of people joining this platform. So thank you so much. One question. I know it is not very easy to construct the external genitalia from female type genitalia to a male type genitalia when the baby is genetically male. So what in terms of constructions of the phallus and the things, in such case, what would you do, Navoda? Because if the baby is genetically male, I'm sorry whether I have missed the answer from, because time to time I had to disconnect. When the baby is genetically male, but the external genitalia is completely that of female, what would be the feasibility for the construction of the external genitalia in our country?
In our country, we have a plastic surgeon.
Yeah.
Actually, he can reconstruct penis. Penile reconstruction is possible. But when it comes to complete androgen insensitivity, if the diagnosis is complete androgen insensitivity worldwide, those patients are brought up as females because it's very easy. They have the lower 1/3 of the vagina and the testes are there, and it will produce testosterone, which gets converted to estrogen, and the breast development will take place. So it's very easy. CAIS, we have to bring up as females. And also Leydig cell hypoplasia, considered to be brought up as females all over the world, because it's of no use. So that is what people think. But female reconstruction, phallic reconstruction is possible. Now you may have heard transgender people, they do get reconstruction, penile reconstruction. It is not impossible, but it involves a lot of surgeries. So as much as possible, we prefer to bring up a 46XY as a boy. And that is why I said it is a big discussion with the urologist, with the plastic surgeon and the surgeon. If the surgeon is happy to give it a try, yes, we would go ahead with penile male sex of praying. And sometimes what they do is they request a short course of testosterone prior to hypospadias correction, and which we can do. And very successful surgeries we have seen. So all in all, our intention is to bring them up as boys, unless the surgical experts and the diagnosis is confirmed of CAIS, we would bring them up as females. I think Janath is.
Yeah.
Janath has raised hand. Yeah, Janath.
Sorry, can you hear me?
Yeah.
Yeah, just what age you would recommend this surgery? Actually, what age do you do these surgeries?
Very good question. So clitoral reduction depends on the size of the clitoris. If it is very disfiguring and it gives discomfort to the child, they do the reconstruction, clitoral reduction before 2 to 3 years of age. Or else with the treatment, sometimes the size of the clitoris reduce. And it is sometimes it's no longer seen between the labia. Then they don't go ahead with clitoral reduction. But when it comes to hypospadias, our intention is to let them pass urine in a standing position before they go to the Montessori. Which means before 3 to 4 years of age, you have to correct the I know it is done in stages. So second stage surgery is done before the baby starts primary school or preschool. Otherwise, it will be a big dilemma for the other people when a boy starts peeing in a sitting position, squatting position. So prevent that problem. Surgeons prefer to do the surgery before they go to the Montessori. In other countries, sometimes after discussing with the parents and the psychologists and all kinds of other people, they don't do anything until the child is big enough to give the consent. So they register in one type of a sex and then let the child decide later on. Anyway, even in our country, we don't do anything irreversible. So that is the most important thing that we have to remember. No irreversible surgeries, but clitoral reduction is done for patients with CAH because if it is very, very disfiguring and it gives discomfort to the child, it has to be done by 1.5 to 2 years of age. And people now have gone away from this repeated vaginal dilatations because it is a psychological trauma to the child. When they start getting menstrual bleeding, it will act as a natural dilator. Unless there is a stricture, you don't have to do repeated vaginal dilatations after vaginoplasty. That is what the people think now.
Okay. Well, just I don't want to add a lot of controversies, but I was trained in Westmead, Australia. They are very strictly say no surgeries.
Yes.
Till they are big enough. Because what the
That's
problem
why I said.
is, the main problem is we are facing here around the world, even completely normal human beings.
They want to change.
2% of them are not happy with their gender.
Yes.
And these kids have much higher chance.
Yes.
So decision making with these so-called experts and psychologists, we never put the individual in perspective. We should never forget that our patient is the child.
That is
So
why
I
we
have,
should not do any
not
irreversible
done,
thing.
I have not involved or done anything here, like probably my training there in Australia. So there is anything you want to do, you have to get the juvenile court approval. So at the moment, they are giving approval to remove gonads in miscegenadal dysgenesis or some other condition when they have high risk of malignancy.
Yeah.
But
even here it is like that. In Sri Lanka, we don't remove gonads until the child is able to give consent. That's what I told you previously. We gave KRH analog.
Even this clitoral reduction and making penises and all sort of things, they wouldn't do anything until at least child is
big enough to give.
14 or 15. So just giving my idea. So we have not personally.
Even at LRH, our surgeon doesn't do anything irreversible. Only the vaginoplasty for CAH patients, hypospadias corrections for 46XY DST. Clitoral reduction is done for severe clitoromegaly. That is still done.
Yeah, so but what if that child grow up?
There's a very big risk of
a boy.
If that child wants to be a boy in CAH, there is a small risk of them wanting to be boys. Then you will have to reverse it. Yeah, even females want to.
You can't reverse it once it's removed because it's not a.
They don't remove. No, they don't remove the clitoris.
The clitoral reduction means they are removing penile erectile tissue. Corpora spongosa, they have to remove. So this is the problem actually. That's what I have seen it. The problem is then they come, they so-called their penis they are making made of skin and fat. It has just
There's no
cosmetic.
function. Yeah.
Yeah,
There's no
yeah, it's
function.
just to make the parents happy. But it will never do any good to the child, definitely. 100%. There is no guarantee that. So all those things, what we are doing to children is horrendous. I think my advice, get the oldest surgeon to do it. Hopefully,
Yeah,
he
that
will
is
be
why
dead.
I sent to the older surgeon at
Hopefully, he will be
LRH.
dead by the time we go to court.
Yeah, most
So,
experienced person in the country is doing that.
yeah. Only benefit is he will be dead, hopefully, by the time they sue you guys. I'm seriously, it's my opinion. I don't want to bombshell it, but as far as I know, in Australian law, I have never seen a single case in Sydney. They don't touch those children. So I know a lot of things happening. Goal, we don't do any gender reassignment surgeries or anything at all. Zero. In children, adult, yes, they do. They
It
do
is
our
not.
class.
It is not reassignment, Janit. As I
Yeah,
told
yeah.
you,
Whatever.
CAIS, we wait till the baby child is big enough to give the consent. 5-alpha reductase, we waited till the child is big enough to give the consent. What I told was, it is possible. When someone asks whether it is possible, yes, it is possible, but we don't do here. Even our plastic surgeon can do it, but we are not doing it. We have patients with aphalia. So that was the time where we discussed this. So for aphalia patient, it is not an endocrine problem, it's an anatomical problem. At that time, he offered reconstructing the penis. So otherwise, we don't do penile reconstruction in patients who are affected with 46XY DST.
Yeah.
We only
I'm
correct the
talking
urethra.
about this clitoral reduction and the vaginal reconstruction thing in the.
I think, Janet, I think your point is clear. I think what Navoda is also trying to say, it is possible to do the recorrection. But on the other hand, what you are trying to say is it's better not to touch until the child can make a decision when the child is big enough. Because I think I have a personal, I have looked into this and I have read and I have gone into the depth. Now the sexual orientation is, the issues with sexual orientation is now, it's very commonly openly discussed issue, and it's given more kind of more weight now in the present world. I think my personal opinion is also, unless it is medically indicated to save the life or something, some kind of indication, otherwise it's always better not to touch until the child is big enough to decide whether I'm going to be a male or female, isn't it? Because
We
now
don't
these
do it.
things, that now these things are more and more common and it's very open, and there's not, these are even the sexual orientation is very openly expressed now. I went to last month I went to my daughter's graduation, and the graduation there was a fellowship of a top class professor, and he openly came to the mic and say, I'm a gay person. And he for something he
He's a
said,
transgender.
so
Transgender.
yes, so these things are now very openly expressed, and so I think the world is very fastly changing on these kind of issues. So I think it's very reasonable, as Janice said, better not to touch until the child is big enough to make a decision.
Main problem is we know now gender assignment is occurring in first trimester probably in people. So it's nothing to do with, it's most likely like 99% of the time genetic makeup decides the gender, but not essentially always. That's one thing, even normal people.
That is why we have a lot of transgenders.
Transgender people, what their calculation is 2% of population is probably not happy with their gender. And the most difficult thing that we have seen these adult patients going through this again. If they have a penis, they pretend they are like, they just enjoy it. But the problem is some of these children have erectile tissue, which can be used, they can use it as, because we have to fundamental basic principle of medicine is autonomy. Autonomy belongs to the patient. That's a fundamental of our medical care. Autonomy is patient has to decide what their life is going to be. We can't be the judges. The problem is when we are managing with the parents, we have to take a decision. But that decision is, other thing is these most surgeries, what we are called here, are belonging to cosmetic category. Cosmetic, their category is augmentation of existing thing. So we are going to change it, augment it to a more male or female way, rather than functional effect of that individual. So if you are really going to the ethical aspect of it, most of these surgeries belong to cosmetics. So that's one thing. Other thing, our country has no laws. We are a lawless country. We don't care about individual freedom. We don't worry about other people's things. We are worried about always what the society think, and what, especially in our parents, they are so much overwhelmed with. You can see, like, if you want to see a Down syndrome child, you have to go to a beach where the foreigners are. You can never see a Down child in a supermarket because our parents will never take it. So they are so over invested with this kind of rubbish, and we always let down. So my point is, I have no personally no zero interest to do any of those things, because I'm dead scared. Like, I'm not scared of litigation. This country probably nothing will happen, but I'm scared that that kid or somebody, when they grow up, might curse whole rest of his life to things if I do anything. Luckily, I haven't, but this is my opinion. I mean, you can
Thank
take
you,
it or
Janit.
leave
I
it.
think that opened up another interesting area for discussion. That's very interesting, and for people to know to make when we want to make decisions. So we have to be very careful. I think what Navoda was trying to explain, it is possible. And probably we are not doing major surgeries to change the sex in early stage. I don't think that we are doing it at a large. Are we, Navoda? I
No,
think
no.
probably no. So
Actually, when the harder stage is 4 and 5, we have to clear the when there's a common urogenital sinus, and when there is a lot of infections going on, they have to
yeah,
separate the urogenital sinus.
yeah, I think that kind of things
That
probably
is what we do. And
warranted.
at the
Yeah.
same time, actually, the surgeons prefer to do a small clitoral reduction. That is what they do here, right?
Yeah, but
And
clitoral reduction, if
they,
you really
they,
look at it,
they
it's
separate the
removal of
common channel.
erectile tissue, and it
Yeah.
is not reversible. It's a
Yeah, I
complete
think probably
mutilating.
it's better not to touch that and leave it and do only the medically indicated kind of surgeries, and leave it for the future references for the child to decide, isn't it? So thank you so much for both of you. I think it's really interesting, and there's so much of things to learn from this discussion. Also, we have to respect uh, the we have to respect the child's view, because which is not expressed at this stage, so which may be expressed another decade or 1.5 decade later, so that view has to be respected. I think that is what we need to learn, and thank you both of you for a very interesting discussion.
Thank you.
Thank you.
Madam, I have one question. We have the common two encountering conditions in our day-to-day practice is bilateral undescended testes and penoscrotal hypospadias. In these two conditions, especially these are the two we encounter. In broader form, at one point we decided to do the pediatric endocrinology referral. So could you please simply explain at which age we need to do, and what are the basic investigation we need to do before we do the referral?
Actually, at least by 2 weeks, we have to see these patients for the appropriate investigation. As I told you earlier, this could be of anything. It could be a testicular defect. It could be a problem with the testosterone action, testosterone activity. So there are a whole lot of things that we have to investigate. Because of that, it is best if you can send those patients by at least by 2 weeks of age, unless you are dealing with a patient with CH, especially the 3 beta. 3 beta, they might have pigmentation and other evidence to suggest ACTH, increased ACTH production. So we generally investigate them just to prevent them coming with collapse and salt wasting, especially those 3 beta. We start investigating these patients with undescended testes and hypospadias by 2 weeks of age. We have to do all the investigations, including HCG stimulation test, depending on the basal testosterone level. So it's good if you can send them at least by 2 weeks. But CAH patients, if the testes are not palpable, yes, by 2nd or 3rd day, we will have to investigate them with 17-OHP.
Okay. The other question is, usually these parents, they are anxious and they usually try to get the information from various sources. So do we have any recommended reading materials for parent education in our country?
We do not have in Sinhala, unfortunately. So what we do is, depending on the condition, because it is a vast area, so if they read the whole lot of 46, especially these 46 XYD ESD, they will get confused. Because of that, depending on the problem that we identify in the patient, we explain according to the diagnosis, underlying diagnosis, not the full length of 46 XYD ESD, which is going to be even difficult for medical students and the medical people. So because of that, we have very limited, we don't have actual reading material. We do counseling only. We will have to prepare translated, patient-friendly, patient information leaflets, especially for patients with CAH, where we have prepared for acute management, surgical management, all those patient information leaflets are there, but not for 46 XY-DSD patients. So I think it's high time that we start it, but it has to depend on the various different conditions. That is why we were a bit late to prepare such a document in Sinhala. Even in English, it's very difficult to find simple form of 46 XY-DSD. We will have to prepare now. Yeah, that's a good eye-opener. Rather than only talking to patients, we should prepare some Sinhala versions also for them to go and read. Yeah, thank you, Jitma. Yeah, you and actually, where is our Sujit? You happen to be in areas with consanguinity, and we used to share a lot of patients with DSD, right?
Yes,
I can't see Ajit and Jitma, the two neonatologists who got exposed to most of these problems. And to tell you, one patient came, not from your unit, patient came without a BCG vaccination because the baby was not given a book, and the nursing officer or the attendant has refused, nursing officer has refused to give the BCG vaccination because there's no book. The color matters, no, whether it is blue or pink. So if you don't give a book, they won't get the BCG vaccination. So remember that also we have to address. Sometimes when you transfer those patients, that is why I said if the testes are there, more likely that we are going to bring them up as a boy. So better to give, the best case is a blue book. If the testes are not there ultrasonically, give them the pink book rather than keeping them in dilemma. In other countries, they asked to register late, they asked to name the patients very late, but certain things are not possible according to our culture. So we have to look at the cultural background also, not only science, not only evidence. Certain things are not applicable 100% to our society. Because of that, it is good if you can send with a book. We may change it later. I have given letters to change the sex because it has been identified later on. There were some patients with 46XY DSD who were labeled as females and around 2 years of age found to be males. So we could give a letter to change the sex of rearing. It is possible, even though the birth certificate, they put a asterisk and say that the sex was changed. So that is why nowadays we don't see them much, because our neonatal services are so good. And even a very mild clitoromegaly is sent for investigation, and it turns out to be normal, for which we are very happy that you identify and detect them before they coming with salt losing crisis. So thank you, all of you, for keeping our problems minimum when it comes to these life-threatening conditions like CH.
Yeah, just a little suggestion now, if they really can't make a decision which book to give, we can always issue 2 books. And
Yes,
because
please do that. Tell your colleagues to do that, so that at least the message is given.
So later on they can throw the unnecessary
Yes.
book. Because this is
Sometimes
not
we have to
happening
get
every month. This is happening very
very
occasionally.
rarely.
So they can always issue 2 books, and that can be coordinated through the consultant to the BCG people, and the other books are issued, and you can request explain the nurse to the nurse and issue 2 books. There's no problem with that.
That's very good.
Jitma, are we okay? Can we wind up?
We have one more question. What is the place of screening suspected babies for CAH by heel prick?
Heel prick screening. Yes, in other countries, they do it. And ideally, it has to be done on day 5. Having said that, even in UK, it is not being done because it is so rare, and they think it is not cost effective, because they tend to identify a lot of non-classic CAH patients. On the other hand, there's an argument, yes, we may miss boys with CAH because they may present with, because they don't have any ambiguity, and they can present with salt losing crisis. For this, we should have cost analysis data to find out whether the screening is useful. And having said that, at the same time, whenever a baby comes to you around 2 to 3 weeks of age with failure to thrive, most of our pediatricians, almost all our pediatricians, do an electrolyte. And the moment they find salt hyponatremia and hyperkalemia, they call us. Even for UTI, they get hyponatremia and hyperkalemia. They call us and manage those patients. So I very rarely see patients dying of not having screening, but I cannot oppose if somebody is for neonatal screening. For that, we need a very big cost analysis. It is not as common as congenital hypothyroidism. So when it comes to screening of a disease, they look at quite a lot of information to see whether it is useful. So that may be the reason why even UK is not doing CAH screening on the heel prick. So I wonder whether at this point, whether we should start doing it, or whether we should be more cautious of patients who are coming with failure to thrive or pigmentation or with family history.
Now so I have to say something about this screening. I think it was done some time back about along with TSH, and I had 1001 problems because of that, because I can't remember, almost every baby or every other baby had abnormal values, and then they wanted to repeat it with a venous sample or whatever, and parents were really,
I faced the same thing, because patients get referred to me. I had to do a synaptome test, and it was very expensive.
Fortunately, that has been stopped now. I think fortunately they are not doing it, and that is one problem. That is one problem. And also in a country where TSH is not properly done, And I think we should not think about
I have never asked
CH.
anybody to go ahead with screening, but if someone is doing it, I'm not going to oppose. That's what I said. But
Yeah,
I'm not for
definitely, definitely.
because at
Yeah.
that time I did so many synapton stimulation tests to find out whether they are actually non-salt losers or salt losers. But what they say is the carriers also can get detected to this neonatal screening. Why UK is not doing is because they will have a whole lot of people who need follow-up, who need counseling throughout the life because of this positive screening test. That is why they are avoiding it. So I don't know why we should get into that issue.
Yeah, you're quite right. Yeah.
But it's a fancy thing to have. Screening for neonatal, screening for CH is a fancy thing, but will leave with a lot of issues. And we can't do 17 OHP from the government sector now. We have to do it from private sector. All of you know that. So if you have to do a lot of unnecessary investigation, it is going to be useless.
In the absence of further questions, I would like to wind up the session today. So I would like to thank Dr. Navoda Atapattu for her excellent presentation and discussion on this forum. And thank you very much for all the participants who involved and in our webinar. So for sponsoring, I would like to thank Sidus Life Sciences for the sponsoring of this program. Good night, everyone.
Good night.